I hope everybody slept well last night. I think we've got some really interesting speakers today, so everybody listen. Okay, I'm going to start this morning with a wonderful human being, Dr. Ishi Bains. Dr. Ishi is a regional primary care clinical lead for gynecology in Tower Hamlets Women's Health Hub clinical lead. Planned care clinical lead NELICB NHS GP CBT insomnia therapist. Wow. The Women's Health Hub was mentioned as an exemplar in the National 10-Year Plan, a huge recognition of the collaborative, patient-centred work being done to transform women's health services. I welcome Dr. Ishi Bains to speak.
Thank you so much. That was such a lovely introduction. So, yes, I'm Dr. Ishi Bains. I'm quite short, just like my mum, Abnash Bains, so I'll be on tiptoes today. I've got a presentation lined up. I don't know if it's available, but I can start. So yes, I'm Dr. Ishi Bains. I'm a GP in the UK in London. I'm also clinical lead for Women's Health for London. And what I'll be starting to talk to you about today first is a new way of working within the NHS that has been transformational, especially with the waiting list in gynecology. So I'll show you the example of what we worked towards, how we got there, our achievements over the last 2 years, and how this is really replicable to every speciality. It isn't just specific to women's health. It's what I use and what we do in health cure. So I'm also a CBT insomnia therapist, so an insomnia therapist, and you'll find out through my talk, a lot of my experience isn't just medical, isn't just from medical school, but it's actually from personal experience, being a mother of 3, having lots of women's health conditions as a result, having insomnia, and so that's what's led me to want to transform the healthcare that we provide in the UK, and hopefully some of those examples can be used in other countries. So that's what I'll be talking to you about today. I can't actually see my presentation, so I'm just going to ask, I'm just going to quickly ask my son or my daughter if they can just quickly grab my phone, because I've got it on my phone and then I don't have to look at the screen. But I'm feeling very honored to be here today because 20 years ago when I finished medical school, my last year we do electives. And elective is when you go to another country and you work for a good 6 to 8 weeks. And the country we chose was actually Tobago. So I was 3 kids lighter then, probably a few kilos lighter too, with a lot less hair, a lot less white hair. So I feel very, very excited to be here with my mother and children and my sister and my nephew here, and for her to host her conference this year in Trinidad, because I came here last, like I said, 20 years ago, and it just hasn't changed. The vibe, it's so chilled, you feel so comfortable, the kids love it as much as I do. So I'm really, really excited to be here and being able to talk about the work that we're doing in the UK to transform women's health. Is that up? Okay, great. Okay, so I'm just going to shout, every time I need to shout, next slide, just change it for me if that's okay. IT is not one of my favorite things in the world, but let's all give it a go. So I'm just going to start off by talking about what we did in the UK and why we did it. So what we found, next slide please. Next slide. Right.
You can push this button and then you have the next slide.
Oh, which one? This? The top one. Okay, let me have a quick look at where we are. Okay, amazing. All right, so why did we feel we needed to transform women's health in the UK, and why am I talking about it? And why did we feel we needed a new approach? The reason being is because the waiting lists in London were ridiculous. From a GP to refer to a specialist in women's health, often the patient would be waiting 18 months. There was convoluted pathways, so it wasn't straightforward often. There was long wait lists, like I just mentioned, and often my patient would come in and say, I finally got an appointment, and then find out that they were booked into the wrong clinic because of the logistics, the administration. We use the National Health Service, the NHS in the UK, and there was just inefficient use of outpatients' capacity. A lot of these patients could have actually been managed in their GP within hours. You know, they might have just needed some hormonal treatment prescribed safely, and that would have saved them the pain or the symptoms they were suffering, with the support of a specialist telling their GP exactly what to prescribe. So that's why we needed to do an outpatients transformation program, and that's why we needed to transform healthcare for women. And also we found there was inequalities in healthcare. You know, if you lived in a certain area, you would often get better healthcare in London. So we needed to make sure that everyone was receiving equal healthcare across London. So we did a lot of patient engagement. We did GP engagement, so primary care engagement, and we did secondary care engagement. And we just basically asked, we did lots of feedback, and we said, what does everyone want? And GPs wanted easier access to specialist advice for their patients. Patients just wanted to be treated quicker in a place closer to home. And secondary care consultants, gynecologists, wanted to be seeing the patients they're supposed to be seeing in the hospital. So that's why we decided to do this project. I hope that's changed. The next slide. If someone could give me a thumbs up. Has it changed? The next slide? Yeah, perfect. Okay, so what did we come up with? We came up with a single point of access. So I'm a GP, I work in primary care, and I'm a lazy GP. I don't want to be looking at, you know, where do I refer? Which clinic do I refer this patient into? How do I manage this patient? And not all of my GP colleagues have an interest in women's health like me. So I thought, okay, how do we make our 10-minute, we only have 10 to 15-minute consultations in primary care in the UK. So how do we make that effective? So we made management pathways accessible on the IT system that GPs use. So essentially asking the right questions and ticking the right boxes. On top of that, it worked as an educational tool. Like I said, I need to do minimum work. So this also, if you saved it, it allowed us to save it as your documentation. Documentation is very important in healthcare service. So it allowed us to do that. But if the GP felt they needed extra support for their patients, all patients with women's health are now referred, a single point of access, to a system which sits under secondary care, so sits under the hospital, and it's triage. Those referrals are triaged. But what we changed is the collaboration. The people triaging them weren't just specialists, they were also doctors who worked in the community, so doctors like myself, GPs, looking at the referrals, seeing what was appropriate to be advised back to the GP, what was appropriate to be seen in a community setting, a specialist community hub, so that's the Women's Health Hub, or referred into gynecology outpatients. So it gave more options to patients, but also made sure that they were managed in the right place. That team, MDT team, multidisciplinary team, isn't just made of doctors, it's made of nurses working together, physios working together, dietitian. We have social prescribers in London where you can refer your patients to an expert who can support them socially with low-level psychological problems, economic problems. They might not be able to afford the materials they need to support them in their women's health. They may have weight problems. We know a lot of women's health conditions, medical conditions, are worse if they're overweight or obese. So we also work closely with them. And this is why collaboration and working together is really important. Then, if that patient needs to go to outpatients, back to the GP, or back or booked into women's health, was done much faster. So, Next slide. So this is the bit that anyone's interested in, and the only reason the government in the UK has taken us seriously is because after 18 months, we were able to show that this way of working could reduce the waiting list. So you're going to be blown away, hopefully, by this, but 18 months for some of our clinics in the Royal London Hospital, which is one of the most renowned hospitals in London, the waiting list for menstrual disorders and general gynae has gone from 18 months to 4 weeks. And that is over 12 months. And I think, thank you. So this is why people are taking us seriously now. And this is why we were mentioned a few times in Parliament as an example of good practice. Oh, something. Yeah, of good practice. So, why are we successful though? What the powers above cannot accept is the reason we're successful is because of happy workforce, working together and putting patients first. It's very hard to measure that, but the reason our project is successful is because we asked GPs, we asked gynecologists, and we asked patients what they wanted. And this is what reduced the waiting list. So from 80% of patients that were referred who were booked into gynecology outpatients, that has reduced down to 33%. So 33% are now seen in gynae outpatients, about 33% are seen in the community hub, and then the rest are actually sent back to their GP with advice. And the GPs are happy because it's supportive advice, and often the advice is, prescribe this pill and that will help your patient. And if there is any concerns afterwards, please just refer back. So it's also about communication. The reason the GPs are accepting this is because of the communication that has been shared with them and the way we're speaking. And kindness goes a long way. If I and someone in secondary care said to me, a consultant said, no, just do this, we're not accepting the referral, I'd have a right huff and I'd send them straight back again. Whereas the way we're communicating, and the reason we're communicating well is because we're working very much together with community doctors, working with hospital-based doctors. So next slide. Sorry, I've just lost it on my phone. Let me just grab. I did warn you, I'm not very good with tech, but let's see if we can get back on it. So I'm not sure what this next slide. Oh, okay. So I'm hoping the next slide says from women's health to sleep health. Is that right? Thank you. Appreciate it. So, like I said, the reason the women's health hubs and this new way of working is because we have a very holistic approach. So what I've done is I've taken this to our practice. So my husband started integrated medical practice quite a few years ago, which really focuses on the root cause of patients. In the NHS, we treat the whole country, and holistic approach and preventative medicine, unfortunately, isn't the priority now, even though in the next 10-year plan, they are trying to make preventative medicine a priority. But the root causes is what we need to do. Otherwise, it's essentially just a vicious cycle. So what working as a women's health lead taught me is the power, the transformational power of collaboration, working together. So even though we're able to often treat the women's health conditions, treat the endometriosis, treat the menopause, treat the pelvic pain, treat the menstrual disorders, what lingers is the associated sleep problems patients have. Because the problem with sleep is it's a habitual thing. So the causes of sleep issues are often things like depression, anxiety, change in routines, health conditions. But once those have gone and been cured, why does insomnia and the sleep issues still remain? I'm someone who had insomnia, and I'm like, but I felt, and I have the bags to, still prove it. So in the sense that, why is it still there? The reason being is because sleep issues is a habitual thing. It becomes a habit. So you have to break the habit. The only evidence-based way to cure insomnia as per NICE guidelines, national guidelines, is actually CBT insomnia. But you do need to treat the patient as a whole. And to treat the patient as a whole, you need to work as a team. So this is what we do in HealthCure. So next slide, please. Sorry, I lost them on my phone. So this was why sleep matters. So in women's health, all conditions affect your sleep. So you'll often hear in the UK, menopause and perimenopause is hot topic. You know, it was endometriosis last year, now it's menopause. And the truth is, sleep is one of the first things that are affected. HRT can help somewhat, but really you need to do not just sleep hygiene, you actually need to break the behavior and the cognitive effects of health conditions that is causing you sleep issues. The consequence of sleep issues is awful, you know, physical fatigue, heightened pain, you know, if you're tired and you lack sleep, you're unable to cope with the pain that you've experienced. It affects your heart and your metabolic system. It reduces the capacity to manage other health conditions. And why is this important in women? One reason it's important in women is, to be honest, we find the lack of sleep quite useful, to be honest. The fact that I had insomnia, when I had each of my children, I was like, oh, this is fine, you know, waking up in the middle of the night. It felt actually, it was actually quite useful. And as a busy working mum who has a few roles, sometimes being awake at night is, you know, where I can send my emails and bother people and get my work done. So it becomes almost a useful, accepted condition. But the problem with it is the consequences. It reduces life expectancy, it ages us, it affects our, like I said, our heart and our gut. So we do need to manage it, and we do need to manage it quickly. But the only way to manage this is, like I said, to treat as a patient as a whole. So we need to treat their physical conditions, their mental health, and this is what we do at HealthCure essentially. But main thing is we need to look at the root causes. So I've gone through this already. Peer support is very important. You know, peer support and social support is important. Talking about things and talking about. Normally, if you actually say to someone next to you, oh yeah, I've got, you know, I don't sleep well, or I have this problem, they usually come back and say, I have the same issues here. So it's always important to have that social support. Lifestyle intervention we've talked about, psychological support, and medical care. It all needs to work together. Right. Let me just have a quick look at what this slide is. Right. I think we've been through this slide, so I don't want to repeat myself. But essentially, I think in conclusion, what I'm trying to say is that we've achieved something huge in the UK when it comes to women's health, and it's very recognized. But this model isn't unique. Collaboration, working with kindness, listening to your patients, but also listening to your colleagues and making the working environment an enjoyable place to work in. I'll be honest with you, NHS doctors are not happy at the moment. It's depressing, they're overworked, they're underpaid, it's not very varied, it can be very repetitive. So creating an environment like the Women's Health Hub, working with different types of colleagues, not just doctors, but nurses, administration. One thing I'll say is our admin staff and our receptionists is actually the glue that sticks us together. Without them, I wouldn't know which direction to walk in, I wouldn't know what the waiting lists are. So working all together and respecting each other in all healthcare and in all new models of care is really important. And what needs to be accepted by the people who are using us as lots of case studies now, and you know, giving us the credit as the leads, which we don't completely deserve because it's actually the whole workforce who have worked together, do not accept is that the numbers are good because the people are happy, and working together really makes a difference. So at that, I think I've talked enough. Any questions? No? Okay. All right, thank you so much. It's lovely, lovely talking with you. Apologies for the technical issues. I'm not going to lie, this is a frequent thing with me. But thank you.